Welcome back, everyone. We're now going to start talking about the anticoagulants and the fibrinolytics. So we are going to be talking about heparin, antithrombin 3 independent thrombin inhibitors, warfarin, streptokinase, and tissue plasminogen activator. Now, just a little overview here. Drugs that inhibit the coagulation cascade can do this via decreasing the activity or level of the clotting factors, increasing the activity or level of the anticoagulation factors, and they can be used to treat thrombotic and thromboembolic disease, to prevent myocardial infarction, ischemic stroke, deep vein thrombosis or DVT, and pulmonary embolisms. Now, when we're talking about the anticoagulants, we have acute ones and long-term ones. In terms of acute, these are ones that are providing short-term control of blood clotting, and they include the heparins. And the heparins act via antithrombin 3, which is a naturally occurring anticoagulant, and they act to activate it. The long-term ones then act to provide long-term control of blood clotting, and these are the antithrombin 3 independent thrombin inhibitors, and also warfarin and related compounds. And warfarin is a vitamin K antagonist. Now, heparins are endogenous, naturally occurring anticoagulants, but they can also be given exogenously to activate antithrombin 3. So they can be extracted from animal lungs or intestines or be produced synthetically. However, the synthetic heparins are smaller, so they are low molecular weight heparin. There are advantages and disadvantages of using full-length unfractionated heparin versus the low molecular weight heparin. However, all heparins activate antithrombin 3. The full-length heparin-bound antithrombin 3 inactivates thrombin and clotting factor X. Thrombin there is 2A. And the low molecular weight heparin-bound antithrombin 3 inactivates clotting factor 10. But both will block the clotting cascade. So if we look at this in a little bit more detail here, we're looking at the interactions of heparin, also antithrombin 3, which is at AT3, and clotting factors. Now, to increase the activation of thrombin, which is 2A, by AT3, heparin needs to interact with both substances, which you can see via these little peak bits here. But to speed up its effect on factor 10, it needs to only interact with AT3, right, in the middle. The low molecular weight heparins, as you can see down the bottom here, will increase the action of antithrombin 3 on the factor 10, but they can't increase the action of AT3 on the 2A, because they can't bind both simultaneously. So we'll go through the full-length unfractionated heparin first. This can be administered via IV, and it will act immediately, or it can be administered via subcutaneous injection, where it acts within 60 minutes. So if you need it to have, a rapid effect, this is the one that you'd go for, the full-length unfractionated heparin IV. It is cleared quickly, so it needs to keep adding more. So it needs to be constantly sort of topped up because it's cleared so quickly. Normally a large dose, so a bolus dose via IV is administered, and then that's followed up with a constant rate infusion. It is difficult to predict the correct dose though, so while somebody is having heparin, you need to do functional blood tests all of the time. And the whole aim of, administration of this heparin is you want to administer sufficient to inhibit the coagulation, but you don't want to give too much because the risk of hemorrhaging if too much is administered. The low molecular weight heparin is only administered under the skin, so there is that delay in activity. So as I mentioned, if you need it to, act quickly, it would be administered, the full length would be administered via IV. It's cleared more slowly, so it only needs to be administered once or twice a day, which is good. The dose is more predictable, and it is cleared by the renal system. So if somebody has renal failure, then, it can't be used. But again, the main risk for any heparin treatment is that it kind of works too well in preventing clots, but promoting hemorrhaging. Now, that's all I'm going to say on the heparins. The antithrombin 3 independent thrombin inhibitors, most of them bind directly to thrombin to inhibit its activity. They are very powerful drugs. Some are as powerful as warfarin, but unfortunately cause other problems such as liver damage. And so this still the most commonly prescribed drug for long-term control of blood clotting is warfarin. And warfarin, as we're going to learn about in a minute, does also have its risks. It's hard to predict the dose. It's also got a very narrow therapeutic index, and it interacts with lots of other drugs as well. But back to these ones here. Some are naturally occurring anticoagulants. For example, isolated from the saliva of blood-sucking leeches and then, synthetically made in the lab to provide this antithrombin 3 independent thrombin inhibition. And because of, all of the issues that occur with warfarin, there's lots of sort of research into these classes of drugs to try to find, a drug that can take the place of warfarin. So warfarin is orally administered, and it's a long-acting anticoagulant. It's a vitamin K antagonist. So in terms of its mode or its mechanism of action, it inhibits the metabolism of vitamin K to the active form of vitamin K. And in doing this, it therefore inhibits the production of active clotting factors 2, 7, 9, and 10 because vitamin K is required to do this. Okay, so let's go through this again. It's a vitamin K antagonist. It inhibits the metabolism of vitamin K to its active form and therefore inhibits the production of these vitamin K dependent clotting factors 2, 7, 9, and 10. There are issues with using warfarin. Clotting factors already produced need to be cleared before the anticoagulant effects will occur. So the initial dose takes several days to take effect. And then after the initial dose takes effect, you might need to sort of change the dose. So subsequent doses then usually take full effect in 2 days and last for 4 to 5 days. And if the dose needs to be changed, for whatever reason, then that's also going to make a change to clotting, and that's why it's really hard to get the dose of warfarin correct. Now, the half-life of warfarin is variable between individuals. Some people clear warfarin very quickly, others don't. They're slow clearance, and I'll go through that with you on the next slide. Warfarin's efficacy is altered by many factors, including diet and also fever. We'll talk about that on the next slide too. The main risk of using warfarin is hemorrhaging, particularly into the bowel or the brain, because remember here it's an anticoagulant, and if it works too well, it can cause bleeding issues. So it does require frequent blood tests to monitor doses. It shouldn't be used by a woman during pregnancy. And it will also be passed on in breast milk in lactating mothers, but this is not thought to be an issue if the baby is receiving vitamin K supplements. Now, warfarin itself does have a narrow therapeutic index, so there's only a narrow range of concentrations where it can be used for its therapeutic effect before it gets to sort of its toxic effect. In terms of metabolism, some people are rapid metabolizers, so there's an increased clearance of warfarin, and in that case, they would need to have an increased dose of warfarin for the required effect. Other people are slow metabolizers, so they have decreased clearance and therefore an increased effect of that dose of warfarin, and therefore they will require lower doses. Dietary changes can also impact on the efficacy of warfarin. Increased vitamin K intake, such as I've just given a few examples here, but you could have spinach and kale and blueberries and lots of other things, but broccoli, avocados, kiwi fruit. By eating a lot of these, you're increasing your vitamin K intake, and therefore you would need to increase the dose of the warfarin to have, the therapeutic effect. Fever. So if somebody has a fever, there's increased clearance of clotting factors. Now remember that warfarin is actually blocking the activation of the clotting factors. So if you, on top of that, have increased clearance of clotting factors, that particular dose then of warfarin will have an increased effect. Warfarin also interacts with different foods. So grapefruit, for example, there is competition for metabolism between warfarin and grapefruit. So this would be a pharmacokinetic interaction. And obviously, the grapefruit sort of winning in this situation then would potentiate the effect of the warfarin. Other drug-drug interactions that occur with warfarin. Warfarin competes with other drugs for binding to albumin. Again, this would be a pharmacokinetic interaction. And depending on which drug sort of binds more tightly to albumin, then, this would be a pharmacokinetic agonistic interaction. Also with antibiotic therapy. So remember, if you're taking a broad spectrum antibiotic for a bacterial infection, you're not only going to wipe out the bad bugs for the infection, but also the microbiome as well. So for a period of time when you're on that antibiotic therapy, there might be decreased bacterial vitamin K synthesis. So again, this will cause an increased effect of the warfarin, because remember, the warfarin is the vitamin K antagonist, but here we've got less vitamin K, so you're going to have an increased effect of warfarin. Moving on to the fibrinolytic or thrombolytic drugs. So these drugs are very powerful drugs, and they're only used in life-threatening emergencies. They enhance the lysis or breakdown of blood clots, and they do this by activating plasminogen, which is converted to plasmin, and then that dissolves the clots and opens up the blood vessels. They can be used in an acute myocardial infarction to reopen blocked or occluded coronary arteries. They can be used for life-threatening venous thrombosis and also pulmonary embolisms. Now, they are fantastic at dissolving clots, but the reason that they're only used in life-threatening conditions is because they're so powerful, they're also going to cause blood vessel damage. And the two we're going to look at are streptokinase and recombinant tissue plasminogen activator. We'll start with streptokinase, and it's obviously an enzyme. It's a fibrinolytic protein isolated from streptococci bacteria. It activates plasminogen. Right, so I want you to cast your mind back to when we were talking in the inflammatory topic about how, fibrin is deposited in infected tissues to wall off the area, right? So to prevent that spread of infection. But this bacteria, right, has evolved to produce this streptokinase, which can break down that fibrin and therefore allow that bacteria to kind of escape and cause, sort of further infection. It's absolutely amazing stuff, if you ask me. But but this streptokinase, can be used to therapeutically to treat clots, right? It needs to be administered IV. It does reduce mortality in myocardial infarction, and its effects are additive with aspirin. It has really strong fibrinolytic action. As I mentioned, it's a bacterial protein. So what response do you think is likely to initiate in the body as a result of administering streptokinase? For anybody that said, antibody-mediated adaptive immune response, you're absolutely correct. So the immune system is going to be sensitized and produce an antibody to the streptokinase, and with that, the development of the antibody comes the development of memory, right? Now, these antibodies against streptokinase usually block its action for about 4 days post-initial dose. It then is going to take at least a year before it can be used again. And if it is and that's because of those memory cells, right? And then that response will be instantaneous. It is very dangerous to use it less than a year post the first administration. And that's because it's going to stimulate a huge inflammatory allergic response that can result in, anaphylactic shock and fever, all of that sort of stuff, unwanted effects. And hypotension can also be caused because the streptokinase causes a burst of plasmin formation, generating kinins. And remember, those kinins are pro-inflammatory themselves. They cause vasodilation. So here we're talking about systemic vasodilation, systemic vascular permeability, and that contributes to that shock. Recombinant tissue plasminogen activator then is this artificially made form of the endogenous, naturally occurring human tissue plasminogen activator. These drugs don't stimulate an immune reaction, and they seem to be more active on fibrin-bound plasminogen, reducing side effects, and therefore they're known to be clot selective. I have a question for you here. Why are fibrinolytics usually only used in serious life-threatening situations? For an example, in acute myocardial infarction. So these fibrinolytics are very powerful. They can dissolve clots and they can reintroduce blood flow, therefore, through the coronary arteries. Okay. Note there are also mechanical methods to open occluded arteries that I mentioned earlier, such as stents and angioplasty. But there are situations where, you know, these fibrinolytics need to be used really kind of rapidly to dissolve those clots. But the main problem with them is they're so powerful that they can cause bleeding and blood vessel damage. So the main risk of these fibrinolytic drugs then is gastrointestinal hemorrhaging and stroke, which are major risks. And they're not to be used in situations where there is known or likely bleeding because of that, because you're just going to get more bleeding, or a history of stroke. They can't be used if somebody has internal bleeding issues or hemorrhagic cerebrovascular disease or during pregnancy. They can't be used if somebody has had an invasive procedure, because the invasive procedure is likely to sort of have damaged blood vessels, and then if you throw in a fibrinolytic drug on top of that, you're going to increase the risk of hemorrhaging. And similarly, if somebody's had a recent trauma that has required sort of vigorous resuscitation, which is going to cause bruising and damaging anyway, and you introduce a fibrinolytic drug, then you're more likely to get this hemorrhaging occurring. So if we now look at a summary of drugs that inhibit blood clots, right? So here we've got a cross section of a blood vessel with an atherosclerotic plaque. You can see the plaque rupturing there. That's going to stimulate platelet adhesion, activation, aggregation, formation of that platelet plug. And then we have activation of clotting factors, the clotting cascade then, and the formation of the thrombus. Okay. So the drugs that we've looked at, some act on platelet aggregation. So we looked at the sort of antiplatelet agents, in particular aspirin, which is an antiplatelet drug. And that is inhibiting the formation of that platelet plug. We also looked at these anticoagulants that are inhibiting the coagulation cascade. And we looked at warfarin. And related compounds, being those vitamin K antagonists. And we also looked at the thrombin inhibitors, so those heparin and full length and those low molecular weight heparins as well. We also looked at those antithrombin 3 independent anticoagulants as well. And then down here, we also looked at these fibrinolytic drugs, or these thrombolytic agents that break down the fibrin clots by activating plasminogen to plasmin, which then dissolves the clot. So if there is a thrombosis, the drugs that are used to treat the thrombosis depends on whether it's an arterial thrombosis or a venous thrombosis. So with the arterial thromboses, remember this is all about the platelets. These are these thrombi that appear white in appearance, and they contain many platelets and leukocytes. So in this case, antiplatelet drugs such as aspirin will be used, and also fibrinolytic drugs. With the venous thromboses, remember these are the red thrombi because they don't contain a lot of platelets. It's all about the red blood cells trapped in fibrin. And so in this case, anticoagulants are often used, such as the heparins and then warfarin, for example, in treatment of a deep vein thrombosis. Okay, I'm going to stop here, and when I come back, it'll be the very final part of this topic on drugs that are used to treat anemia.